I've been given this topic of hypertension management and lifestyle and medical therapies, state-of-art recommendations. So I'm going to speak on, so the comprehensive description of the management of hypertension, an acronym has been given called Master Plan. M indicating measure the blood pressure, A standing for assessment of the blood pressure, ST standing for selection of therapy, and ER as evaluating the response. So this is the master plan, how to go about in evaluating a patient with hypertension. This master plan is the same diagrammatic way. I think one of the important things to remember is appropriate measurement of blood pressure. And then the cutoff points for labeling a patient as hypertension. In the office blood pressure measurement, it is taken as anything more than 140 systolic or 90 diastolic. And if the measurement of the blood pressure is at the house, the cutoff is more than 135 and 85. And if you are using an ambulatory blood pressure monitoring, overall, if you take it, anything more than 120 by 80 is taken as hypertension. And again, even in the ambulatory blood pressure monitoring, you need to compare the morning values with the night values and then see whether they are dippers or non-dippers, because it has got some prognostic utility. So assessment of the patient should include the level of blood pressure and try to find out whether there are any secondary causes for blood pressure, which the next subsequent speaker is going to tell us more about it. Evaluate the presence of target organ damage, and then when to refer to a hypertension specialist in case you get into difficulties, either in evaluation or in the management of hypertension. These are the broad categories, assessment-wise. I think one of the fundamental things in the management of hypertension is risk stratification of hypertension. And this risk stratification is based on 4 variables. 1, the level of blood pressure. 2, the presence of target organ damage. 3, presence of risk factors. And 4, presence of a clinical vascular disease. The more the number you have, the higher is the risk. So a patient who is just hypertension with no target organ damage probably has the least risk of developing a vascular events. On the contrary, the patient has a clinical vascular disease and then a hypertension with all the risk factors probably runs the highest risk for adverse events over the next 10 years. So once you assess confirm the diagnosis of hypertension, evaluate for the presence of secondary hypertension, evaluate coexisting vascular events and risk factors, then choosing the therapy. Select the therapy for hypertension. As I said, if it is only grade 1 hypertension with no other risk factors, probably you need to give a lifestyle management at least for a period of 3 months before you move on to the pharmacotherapy. It's important to emphasize to the patient that once we start a pharmacotherapy, it is for the rest of the life. And that's really is important to drive home, because some of the patients think that when the blood pressure is controlled, they can be off the treatment with the drugs. This has to be re-emphasized to the patients. And it is equally important that lifestyle measures should not only be the first line of treatment, but it should go on parallelly along with pharmacological treatments. And it's not difficult to do this lifestyle management, but in this present day and age, where time is a premium, then probably most of the people are not following the lifestyle changes that should help in control of blood pressure. So these are the lifestyle modifications. One is the control of the weight. Second is control of the food and the drinks. And third is controlling your stress and probably avoiding some of the toxic elements in your life. So these are all the important things broadly. So the first thing is, I will not go into the details of each one because time does not permit me. But some of the things have come as important things like weight management in hypertension. Does it really decrease of the weight, decrease the hypertension? Answer is yes. And obesity is increasing all over the world, including in our country. In adults, it has tripled. In children, it is almost fourfold. The presence of obesity really doubles the risk of hypertension. And not only that, it also increases the risk of other metabolic risk factors like diabetes. So even the metrics of obesity is changing constantly. We have been using BMI as one of the metric. Then we went on to develop waist circumference as one of the metric for obesity and prediction of the vascular events. And we also went on to develop waist-hip ratio, different in males and females, as a predictor or as a metric of obesity, and thus the risk for vascular events. The present metric of obesity now is waist circumference to the height ratio. It has to be less than 0.5 to say that you are not obese. So weight reduction, the blood pressure, probably if you do diet and physical activity, the decrease in weight may be about 2% and at the most 5% of the body weight. If you are using some of the drugs like lipase inhibitors in the gut, like orlistat, you may lose approximately about 5% of the body weight. And the newer drugs, that is GLP receptor agonists, and the combinations of that is tirzepatide and semaglutide, they are more powerful. They can reduce the weight by as much as 10 to 15%. Individual variations are still there. And of course, finally, the most powerful weight-reducing procedure is the bariatric metabolic surgery, which can reduce the weight by as much as 30%. I think it's generally believed that for every 1 kg decrease in the body weight, there will be a decrease of systolic blood pressure by about 1 millimeter of mercury. How does weight reduction really reduce the blood pressure? Probably by decreasing the sympathetic activity and improving insulin sensitivity. But it is important to understand that most of the drugs which are weight reducing have had undesirable side effects. Some of them induced pulmonary hypertension, some of them induced valvular abnormalities. But even the GLP receptor agonists also have got an undesirable side effect, which has been brought to light recently, the so-called sudden loss of vision, painless loss of vision, what we call non-arteritic anterior ischemic optic neuropathy. And in one study, using semaglutide, it has been shown to occur almost in 6% of the patients, which is a hell of a lot. When you see the control values of 0.8%, so it's almost about 10 times the risk of developing a loss of vision. This loss of vision occurs without pain, and most of the time it is not reversible, or at least the reverse may be only partial. It is never complete in these patients. So there is a risk in using it, and I think you need to keep that in mind before you prescribe it. Intermittent fasting has become the fad of the day, and many people believe that it is better than many ways of fasting. By intermittent fasting, there is a trigger of the metabolic switch from hepatic glucose metabolism to adipose tissue ketone formation. And then this fasting also lowers sympathetic nervous activity, suppression of the inflammation, and improves glucose regulations. But by and large, most of the studies have shown that intermittent fasting is not superior to general calorie restriction diet. So if you like it, you can do it, but it is no better than a general reduction in the calorie content. Appropriate sleep is very important for maintaining your sleep hygiene. To have what we call an appropriate sleep, you need to have 7 to 9 hours of sleep per night. Poor sleep results in overactivity of the sympathetic and consequently the rise in the blood pressure. It's important to remember that obstructive sleep apnea is one of the important causes for secondary hypertension. And screening for sleep disorders in conditions like resistant hypertension and nocturnal hypertension is very important because the therapy of obstructive sleep apnea is totally different. It is not pharmacological. It is basically application of the BiPAP and CPAP. Pollution exposure has become very common. It is beyond our control. It is mostly related to the government actions. The mechanism seems to be the particulate matter seems to cause vasoconstriction of the arteries with vascular inflammation and endothelial dysfunction. How do we get around the problem? Probably one of the ways is exercise at places away from the busy, high polluting areas, and consider using a ventilator system with filtration at your houses. Practical or not, I'm not very sure. Now there are behavior interventions like basically wearing the digital wearables to remind the drug intake and to track the physical activity, and it can also use it for communication with the doctor. So these are all useful but not been tested in clinical trials. Stress reduction is one of the important things because everybody seems to undergo a lot of stress in this modern day, and a lot of various methods are there, including meditation, yoga. But it is important to remember that meditation and yoga are something like a pharmacological therapy. As long as you do it, it works. The day you stop it, the effect wears off. Interesting that listening to the music once daily for 25 minutes has got a soothing effect. It does reduce the stress. Pharmacotherapy of hypertension is very important, but I think it is important to remember that 60 to 70% of the patients with hypertension require 2 or more drugs. And to reduce the pill burden, probably a single pill with more than one drug in the combination is the desired one, so the compliance with the drug therapy will be more effective. I think the first combination of the drugs is probably combining an ACE inhibitor or ARB, either with a calcium channel blocker or with a diuretic is the first drug of choice. Depending upon the response, you can adjust the dosage or add subsequently other drugs. Worth remembering that in the ESC, or the European Society of Hypertension, they still recommend that beta blockers may be used as one of the drugs, effective, and even in those people where there is no compelling indications like hypertension with coronary artery disease, it can be used, it is effective, and it does decrease the vascular events in some of the studies, although not in all of them. Basically now, so the more the number of drugs that you require, I think you need to really look into secondary causes of hypertension and see whether drug compliance is present or whether he is doing any indiscreet eating like consumption of the salt. Important to remember that there are drugs used for other conditions which might potentiate or which might worsen the blood pressure. So a drug history in these patients where the blood pressure has been unresponsive is one of the fundamental things one should do it. The target blood pressure for many adults is basically 130/80 or less, but then it may not be applicable to all the patients, especially in the elderly beyond the age of 80 years. So you need to consider a slightly more liberal levels of blood pressure to achieve in patients who are frail and who are severely dependent, where the target blood pressure of 150 or even 160 may be practical rather than pushing them to 130/80. It's important to remember that don't push the blood pressure to 120/70 or less than that, because there is no data to show that 120/70 or 120/80 has got a better outcome compared to 130/80. And there's a real danger that you might precipitate vascular events in some of the patients. So not only you should prescribe the drugs to the patient, but I think you need to evaluate periodically about the effectiveness of your treatment, compliance with the drug therapy, and complications of drug therapy. Sometimes it is said that hypertension is a silent killer, and most of the patients who have uncontrolled blood pressure will never know unless they check the blood pressure. But now in this modern day and age, we have got a new problem. Everybody has got a digital BP apparatus, and they do not know how to measure the blood pressure. They do it in a very odd way, whatever way they think. And then they keep calling the doctor saying that their blood pressure is high or low. And worst part of that whole thing is that they try to adjust the drugs on their own, depending upon their perception of the blood pressure. If they find that the blood pressure is more by 10 millimeters, they increase the dosage of the drug. If they find that the blood pressure is on the lower side, they try to decrease the blood pressure. I think we have started a program of educating the patients how to take the blood pressure at home, and we are giving cards about what is the position of the patient, how to apply the cuff, how many times you should measure, and you should take the average of the two, all these things. They say that it's too cumbersome to do it, but that is the only way to measure the blood pressure very accurately, and then so that you can adjust the drugs. Okay, in summary, accurate measurement of blood pressure both in the office and out of office is very important to make a diagnosis of hypertension. Lifestyle measures are very important. They are an integral part of hypertension, even with drug therapy. A lot of people believe that if I'm taking drugs, there's no need for any lifestyle management. That is a mistake. The target blood pressure for many adults is only 130 by 80 millimeters of mercury. And probably it may be a bit liberal in very elderly and in the very frail patients. And you need to emphasize that the pharmacotherapy is for lifelong, not for a short duration of period. Thank you, ladies and gentlemen, for your attention.